Welcome to this explainer. Today, we're diving straight into a classic, high-stakes medical mystery. We're talking about that intense intersection where cardiology and endocrinology literally collide, amiodarone-induced thyroid disease. We're going to map out exactly how a drug designed to save the heart can inadvertently completely sabotage the thyroid. And, well, more importantly, we'll cover how you can navigate this complex dynamic when you're the one stuck holding the on-call pager.
So, picture this. You're the medical registrar on call. You get paged to see a 78-year-old guy. He's got a history of heart failure and atrial fibrillation, which, has been nicely managed with amiodarone for years. But today he rolls in with fast AF, a rapid ventricular response that is just completely ignoring your standard rate control. You're pushing beta blockers, and absolutely nothing happens. He's sweaty, he's losing weight, and his heart is failing simply because it's beating way too fast. So why isn't the heart responding? Well, because the heart actually isn't the root of the problem here. It's the thyroid. The thyroid is the hidden engine driving this whole cardiac crisis. And if you don't recognize and treat the thyroid, no amount of cardiac meds is going to stabilize him.
Now, the absolutely crucial point here is understanding the chemical payload of the drug itself. Amiodarone is unique. Why? Because it is a staggering 37% iodine by weight. Just let that sink in for a second. Think about the massive contrast between this single tiny 200 milligram tablet and the profound impact it has on the thyroid gland. It's delivering roughly 75 milligrams of organic iodine. That's literally hundreds of times the recommended daily intake of iodine, just flooding straight into your patient's system every single day.
And looking at this comparison, it brilliantly illustrates the ultimate double-edged sword we're dealing with. On one hand, you've got the intended clinical effect, right? We use amiodarone to stabilize the cardiac rhythm and save the heart from lethal arrhythmias. Huge win. But on the other hand, we face this severe, unintended consequence. This massive iodine overload can completely destabilize the thyroid gland, which, and here's the ultimate irony, ends up worsening the exact cardiac condition we were trying to treat in the first place.
Okay, so let's move into our next section. Inside the thyroid factory, understanding the mechanisms.
To truly grasp how this happens, it helps to look inside the thyroid factory. Now, this factory can fail in three very specific ways. First up, the raw material overload. The factory basically gets hit with so much iodine that it institutes a protective shutdown protocol, just to prevent massive overproduction. Clinically, you know this as the Wolff-Chaikoff effect, which leads to amiodarone-induced hypothyroidism, or AIH. Second is the overactive factory. If a patient already has a kind of leaky factory, say latent Graves' disease, this massive iodine load acts literally like throwing gasoline on a fire. The factory uses that excess fuel to synthesize way too much hormone. We call this type 1 amiodarone-induced thyrotoxicosis. And finally, step 3, the exploding factory. Here the drug is directly toxic. The literal walls of the factory just burst open, leaking all that pre-stored hormone directly into the bloodstream. This destructive thyroiditis is your type 2 AIT.
Right, let's look at decoding the thyroid crisis with some on-the-ground clinical reasoning.
So now that we understand the factory mechanics, how do we actually decode this crisis on the ward? Whenever you see a patient on amiodarone with abnormal TFTs, your brain has got to immediately ask one fundamental question. Is this hypo or hyper? This is your absolute critical first fork in the road. Honestly, you cannot proceed until you've answered this, because the treatments, they're complete polar opposites.
Let's compare two real-world presentations side by side. On the ICE side, we have case A, the sluggish patient. They present with weight gain, cold intolerance, a high TSH of maybe 15, and a low T4. This is the factory shutting down, your amiodarone-induced hypothyroidism. Now contrast that with the fire side, case B, the vibrating patient. They show up with new onset palpitations, a fully suppressed TSH, and sky-high T4 and T3. This is either the overactive or the exploding factory, amiodarone-induced thyrotoxicosis. Recognizing which of these two opposing profiles you're looking at is, well, it's absolutely essential for your very next move.
And that brings us to what is arguably our hardest diagnostic challenge. If your patient is hyperthyroid, like our fire patient, you absolutely have to figure out if it's type 1 or type 2 AIT. Why? Because again, you treat them entirely differently. Just take a look at the matrix here. Type 1 happens in an already abnormal gland, while type 2 usually strikes a previously normal gland. But the real tiebreaker? That's the color flow Doppler ultrasound. In type 1, the factory is working overtime synthesizing new hormones, so you're going to see increased vascularity. In type 2, the factory is literally being destroyed and simply leaking what it already has, so vascularity is decreased or even completely absent.
Okay, moving on to targeted treatment protocols. Fixing the factory. Once you've successfully categorized the dysfunction, it's time to actually fix the factory. And here's your treatment blueprint. If it's hypothyroidism, the fix is pretty straightforward. Start levothyroxine to replace what's missing. And crucially, you usually continue the amiodarone because, hey, the heart still needs it. Now, what about the hyperthyroid states? For type 1 AIT, where the factory is over-synthesizing, you need high-dose thianamides like carbamazole to block that production. But pay super close attention here. Carbamazole will completely fail in type 2 AIT. Why is that? Because thianamides only block synthesis. In type 2, the hormone is already made. It's just spilling out of damaged cells. Therefore, for type 2, you've got to use glucocorticoids like prednisolone to shut down that inflammatory leak. And what if you're stuck in a mixed or uncertain picture? Well, you just hit them with both thianamides and steroids until the diagnosis becomes clear.
Now, before we talk emergencies, let's look at this absolutely fascinating diagnostic trap, amio-TFTs. Think of it as a clinical bear trap just waiting to snap shut on an unsuspecting doctor. Even in perfectly healthy patients with totally normal thyroid function, amiodarone naturally blocks the peripheral conversion of T4 into T3. So if you run standard labs on an otherwise totally fine patient taking this drug, you should expect to see a slightly high T4 and a slightly low T3. Recognizing this physiological adaptation is key. It prevents you from panicking and overtreating what is, in reality, a perfectly normal response.
All right, let's wrap up with our on-call survival rules, avoiding fatal mistakes.
Pivoting to the truly urgent, high-stakes side of things, you must first recognize the red flags that demand immediate escalation to both endocrinology and cardiology. If your patient on amiodarone develops a fever, severe agitation, and extreme tachycardia, you are very likely looking at a full-blown thyroid storm. Secondly, remember our hook from the very beginning. If you have an AF patient who is just completely ignoring double doses of beta blockers, you have to check their TFTs immediately. The thyroid is driving the crash.
To make sure you don't freeze up when the pressure is on, a really great framework is this 1-2 punch system. Type 1 AIT equals 1 abnormal gland, and you treat it with thianamides. Just remember T for type 1. Type 2 AIT equals 2 toxic effects on the cells, and you treat it with steroids. Remember S for the second type. It's just a simple, super effective connection to lock away for your next night shift or your Viva exams.
We're going to end this explainer with the absolute golden rule of amiodarone-induced thyroid disease. Never stop amiodarone with the cardiologist's blessing. Look, I get it. It is incredibly tempting to just stop the offending drug. But amiodarone has a massive half-life. We're talking 50 to 100 days. That iodine is going to sit in their system for months regardless of what you do. So stopping the drug today will absolutely not fix the patient's thyroid tomorrow. But pulling away that antiarrhythmic safety net, that might just cause a fatal cardiac event tonight. Always, always treat the thyroid to save the heart. So what will you check first the next time you see refractory AF on